are looking in the back of your eye. So you doing the eye chart with the letters, that's not enough, okay? They have to be taking pictures and looking at the back of your eye. And some offices now do have a camera that can look at the back of your eye and take pictures. So that's reasonable too, but just doing the eye chart or something like that isn't enough. You want to make sure they're looking at the back of your eye every year. Sometimes if you've had normal exams several times in a row, you might be able to space it out to every 2 years, and sometimes you may have to come back more frequently if they're noticing progression. Retinopathy can worsen during pregnancy as well, so pregnant women are supposed to have an eye exam every trimester, every 3 months of pregnancy. Next slide. Another important thing to protect your health is getting your vaccinations or immunizations up to date. Some of these you may have already had in the past, but some of them you may not have had before, depending on kind of your state in life or your age. For hepatitis B, if you're over the age of 60, you want to ask your provider about that if it's appropriate for you to get that medication. But if you're under 60, you should be vaccinated against hepatitis B. For HPV or human papillomavirus, that's the vaccine that can prevent cancer, so that's amazing, right? So if you're under 26, you should get vaccinated. 9 to 26 is the age in which it's approved. If you're 27 to 45, you can ask your provider. So I remember when the HPV vaccine came out, I was over 26, so I asked my provider about vaccination, and I still got it. So I was like, I want to prevent cancer. That sounds great. Don't see a downside. Let's do this. So it's a great idea. And so you also want to get your flu shot yearly to prevent illness. This is absolutely cold and flu season. We are full to the brim at the Children's Hospital and overflowing into the hallways of the ER because of all the flu and COVID and RSV right now. So get your flu shot, get your COVID vaccine and all your boosters. Every 10 years, you should also be getting your tetanus and whooping cough vaccine updated, and then your shingles vaccine if you're over 50. This slide talks about getting your pneumonia vaccine or your pneumococcal vaccine, and that's usually more of a one-time thing. And then depending on your other medical conditions and your age, it may be that you get one or both of these in particular order. So talk to your doctor about getting that if you haven't had your pneumococcal vaccine updated. And then for autoimmune diseases, type 1 diabetes is an autoimmune condition. That means the body, instead of fighting off infection, it still fights off infection, but it got a little bit confused and decided to attack the pancreas, and so it attacked the factories that make insulin, and that's why you get type 1 diabetes. And so with that, you are at a slightly increased risk of getting other autoimmune diseases, like thyroid disease or celiac disease, which is an allergy to gluten or wheat. So usually we screen for these with blood work at diagnosis, and also once a year for thyroid to make sure the thyroid gland is functioning well. And then for celiac disease, currently the recommendation for children is at 2 and 5 years after diagnosis. And then for adults with type 1 diabetes, screening if there's symptoms. So symptoms you might see of celiac disease would be nausea, vomiting, diarrhea, unexplained rashes, unexplained low blood sugars, weight loss, anemia, low vitamin D levels. Those can be some of the symptoms. But also the reason we screen kids is because sometimes they don't have symptoms. So it is important to get that screening lab work done too. And then for those with type 2 diabetes, it is important for your doctor to be assessing you for your risk of non-alcoholic fatty liver disease, and that can be done with blood work or an ultrasound. So in your yearly blood work, they can be checking your ALT level, which is one of your liver enzymes, and making sure that if it's elevated, they follow up and help you with that. Now, with non-alcoholic fatty liver disease, controlling the blood sugar is one great treatment. Reducing the amount of simple carbs you take in. So simple carbs would be like desserts would be example of simple carbs because of the sugar content. Sodas, including Sprite and ginger ale, okay? Sweet tea, all right? Lemonade, even things made with natural sugars, if we're eating them in excess, like fruit, if we're having more than 3 servings a day, that's a simple sugar too a lot of the time. So just being healthy, modifying your diet, and then actually taking a vitamin E supplement can also be helpful. So talk to your provider about that if that is happening. I'm sorry, I have not been saying next slide. Next slide. Low testosterone in men can occur in diabetes, and we call that hypogonadism. So if you're having symptoms of decreased libido or activity or erectile dysfunction, consider getting screened with a morning testosterone level. Okay. Next slide. Mental health is super important in keeping control of your diabetes. You cannot pour from an empty cup. So if you are struggling with anxiety or depression or disordered eating or cognitive issues, it's going to be hard for you to care for your diabetes, which can sometimes be a pretty complex medical condition. So managing chronic illness can be a burden sometimes. It can create worry and frustration and burnout, not just for people with diabetes, but also for caregivers and loved ones. So super important to be taking care of your mental health as well. Your provider should be completing mental health screenings for you. Periodically, we do it at least once a year in our clinic, checking for depression. And if you need mental health support, you can discuss that with your doctor, or you can reach out to your county health department. There's a department of mental health in every county, okay? And so if you even just search, let's say I looked up Orangeburg yesterday, Orangeburg Department of Mental Health, it will bring up their website, and you can see your local community's mental health centers that you can go to and get help. Also, to the right over here is the graphic of the American Diabetes Association. They have a mental health professionals directory that you can use to find mental health support, or searching psychologytoday.com is a great way to find psychologists and counselors in your area that accept your insurance, and you can specify if you want male, female, etc. So it's a great resource. Sleep. Next slide. Sleep. Sleep is super important to your health in general, but there are conditions that are more common in those with diabetes. So sleep apnea affects about 80 million people. And a lot of people are unaware that they have sleep apnea, or may just think, oh, I just snore, it's fine. But symptoms you want to watch out for are snoring, pauses in breathing while sleeping. So if you've ever watched a loved one sleep and they seem to miss a breath, that could be sleep apnea, okay? Daytime sleepiness as well can be a side effect of having sleep apnea, because the body's not getting enough, oxygen or breath when you sleep at night. So that can make you really tired during the day. It can also affect your diabetes. So it can cause what we call insulin resistance, where you need more insulin or medication, or your body needs to produce more and more insulin to get your blood sugars down. It can also elevate your blood pressure and give you issues with heart disease. You can have morning headaches, and then poor motivation, depression, and fatigue. And so since it can affect your ability to care for your diabetes, it's super important, if you already have sleep apnea, to wear your CPAP or BiPAP at night. And if you think you might have it, going and getting checked with a sleep study. They can sometimes even do like a daytime sleep study if needed, or a home one. But either way, if you're having a lot of snoring issues and fatigue, it's a good idea to get checked out. Next slide. And last but not least, vitamin D. So vitamin D deficiency has been, I don't know if I'd say a hot topic more recently, but I feel like in the last 10 years it really got like a really popular outlook in medicine, because low levels are linked to a lot of health conditions. So vitamin D deficiency may increase your risk of developing diabetes, both type 1 and type 2. And vitamin D levels, when they're low, could increase your insulin resistance, which we just talked about, and decrease the amount of insulin you're putting out there when you have type 2 diabetes. Adults typically need between 600 and 800 units of vitamin D per day. So you can talk to your doctor about getting your vitamin D level measured. It's also important for your bone health. Some people also feel more run down and fatigued when their vitamin D is low. So it's really important in a lot of conditions. Sources of vitamin D. Some of these don't sound too appetizing, but cod liver oil. Salmon is delicious, so we'll give you that one. Swordfish, tuna, those are okay. Orange juice, which moderation, because our sugar levels. But orange juices, dairy, and plant milks can be fortified with vitamin D, and some also have calcium as well. But if you're drinking like almond milk or oat milk or soy, make sure you look at the back of the carton on the nutrition facts to make sure it actually is fortified, because not all of them have vitamin D in them. So your milk source may not have vitamin D if you don't specifically look. sardines, beef liver, egg yolks, cereals. A lot of cereals are fortified with vitamin D and usually says on the back of the nutrition label. And then sun exposure can help you raise your vitamin D levels, but usually it's a good 20 minutes a day without sunscreen, which I know a lot of us don't spend necessarily 20 minutes a day out in the sun every day, right? Especially in the winter, especially our dark complexion doesn't absorb that sunlight as well. And so chronically having vitamin D levels that are low are super common, even in areas in the South where it's warm and nice a lot of the year. But definitely when I lived in the Midwest, it was a lot more common. And I still take my vitamin D supplement to this day because my levels are just chronically low. So that's a healthy thing that you can do for your body as well. So in summary, your body is a temple. It's a living sacrifice. We have to treat it as such. You only get one. And so taking care of your health in a holistic manner, the whole body, is really important. Thank you.
So we're going to take a break, but before we do that, do we have any questions for the good doctor? Okay, Sister Grippon.
Yeah, that's a great question. So with type 1 diabetes, it is called juvenile diabetes often as well, but adults can actually be diagnosed with type 1 diabetes also. So like you may be, especially in your early teens and 20s, or late teens and 20s, that can still be a really common diagnosis. And sometimes people who thought they were type 2 for a long time can later on be kind of diagnosed as type 1. So it's not necessarily that it's only in young people, but usually if you get type 1 diabetes as a young age, it is going to be, a lifelong condition where you do need insulin. And type 1 diabetes is not brought on by eating certain things or eating too much sugar or weight or anything like that. It's really nothing you can do that has caused you to have type 1 diabetes. It's just something that happens in your body where your immune system gets a little bit confused. It attacks your insulin-producing cells in your pancreas. As those cells die off, you start to get more thirsty, drink a lot, pee a lot, your blood sugars go up, and your treatment is insulin to replace that deficiency. With type 2 diabetes, we used to think of it more as an adult onset condition, but now more and more children are becoming obese and overweight. That affects about 30% of our children. And so type 2 diabetes occurs more often in those who have a family history of diabetes, and for those who do struggle with their weight as well can be a risk factor. And so now we are diagnosing type 2 diabetes. My youngest patient is about 8. So it's becoming very, very common. And the difficult part in that is that there aren't great medications approved for children that age with type 2 diabetes. If we think about for adults, which our next speaker will talk about, there's so many more medication options, but for children, it's really mainly metformin and insulin for type 2 diabetes right now. We are getting more medicines approved, but it's definitely a difficult thing now, and that a lot more children are getting type 2. That's a great question. Yeah, that's a great question. So like olive oil and walnut oil is considered to be like more healthy on the Mediterranean diet. Some of it has to do with the type of fat that's in the oil. And so like olive oil and walnut oil and avocado oil, things of that nature tend to be a little bit healthier than like using like usually we use vegetable and canola oil less often now in cooking, less Crisco, less butter, trying to use a healthier type of fat. Mm-hmm. Yes, ma'am? For type 2 diabetes, some people are able to get their type 2 diabetes into, I call it remission. So you are able to.
He said retinopathy.
Oh, retinopathy. Oh, I'm sorry. I thought you were talking about diabetes. Thank you for clarifying. I could not hear. There's not really a great way to reverse retinopathy. You can certainly slow the progression down by then reverting back to those healthier habits. But there's not a great way to completely reverse it and take that eye back to baseline. So the best way is to try to prevent it, and then if you do have it, to, follow the healthy guidelines to try to keep it from progressing. Same thing. It's kind of like the hard part about the nerves and the blood vessels is once that damage is done, it's really hard to reverse. So that's why we really want to prevent it and then treat it if it is happening. So like gabapentin might be a common medicine you use for that burning, tingling sensation. But yeah, it's really hard to reverse it or make it, better or revert once it happens. So our main thing is prevention and then treatment. Good question. Yes. Any other to treat neuropathy? Thank you. The kids I see, we're usually in that prevention stage, so we don't have to treat it quite as much. So thank you so much for the adult medicine perspective.
Let's give God thanks and praise for Dr. Matlock.
Thank you.
Hey, Doc, I'm going to tell you this, and this is the truth. I mentioned it earlier, I've been diabetic since 1998, but my eye doctor has the machine that can take the picture of the eye. So I put my eye up close to it, and she says, look, and then I can look, and so I don't have to have the dilation. So it's really helpful because you can go in versus having to have the big dark glasses. In fact, I never had the dark glasses. I used to say, why do these people have all these dark glasses on? Got my eyes dilated. But I've never had to do that because they have the machine. I think it costs a little more, but it's a good investment. That way you can drive and don't have the dark glasses. But everything you said was A-okay. Now, I just have one question.
Sure.
And I'm gonna probably ask the same question to you also, Dr. Kimbrough, because I want the right answer. So we go to the doctor. They always say we're overweight. They use their wrong chart. That's called BMI, is make you feel bad chart. So what is the right weight? Because the weight they have for me, it's just like fairy tale. I'll never be that. So what is the right weight?
That is a great
Or do you want to leave that to?
No, I'll answer that one.
Okay, go ahead.
I also do our weight management clinic for pediatrics too. So
Okay.
So that's the tricky part. And some might say too, the BMI chart also may not account for different races and ethnicities. Mm-hmm. So there's been an argument in that. So there's actually other ways you can measure what we call body composition, right? So there are ways to measure that instead. So some people will use waist circumference as a measure, because usually when we carry that kind of middle central weight, that's going to be a less healthy weight gain than if we carry it sort of all over. So that's one way to kind of measure the difference, right? You can also use a measure of your body fat too. So that might be a better measure because let's say, Dwayne "The Rock" Johnson, right? He is going to technically be obese if you put his BMI on the chart, right?
Right.
But it's because he's all muscle, right? So if you measure his body fat, it would probably be a lot lower than what you would see compared to BMI. So that's not always the best measure, and it's not necessarily the best measure of our health. And usually I say to people, for weight, it's not about being a particular number on the scale or a certain size. It's about the health that comes with it, right? So even someone, it's tricky because you may say, well, I've been working at this, I lost weight, and it still doesn't seem to be helping. But if your blood work numbers and your blood pressure and all those things are getting better, that's really the true test of what you want to focus on from a health perspective. And sometimes it may be losing, 20 pounds is enough to kind of get your numbers back to a good place, okay? So I usually say let's focus on those other health numbers instead of just the weight, because there are people who are thin who have type 2 diabetes and high blood pressure and other health issues, and there are people who may be considered overweight or obese who don't. So those healthy habits being in place is really the most important part too.
So we can throw the BMI out. We don't need it.
Now don't throw it all the way out, because they're trying to tell you, trying to prevent things, right? So if we see, okay, our weight is, a little up there, a little off the chart a little bit, and our blood pressure is high, right? So maybe that's something that we try to work on, healthier eating and exercise, all right? Knowing that that might get us to the point where our blood pressure is low enough where we maybe don't need the medicine. Or if we start the DASH diet, you'll probably see your weight come down anyway, okay? So don't throw it completely out. And if you feel like your BMI, is kind of skewed, you can always do a different form of measuring your body composition, okay? But I usually say just don't let the numbers get you down, My BMI is on the upper end. I'm working on it, right? But my labs are great. So that's what I focus on. And I say the weight will go the way it's supposed to go. All right?
Thank God for you. Let's give God thanks and praise for her. Dr. Madeline, I don't know if you have to leave, but okay, we'll wait to the end. We appreciate that. Listen, everybody take a grown-up break to do whatever you need to do. And in about 5 minutes, we'll come back and we'll hear from Dr. Kimbrough. Take a break. Yes, ma'am. So you know she's not playing. Come on in, everybody. Come on in, where the table is spread. And because Dr. Matlock talked to us about so many healthy foods, we're going to have a lunch for you today. Those of you who register, we have a special lunch, and it's going to have a little cod liver oil in it and some sardine sandwiches for you because we want you to be healthy. So make sure you get your cod liver oil and sardine sandwiches for lunch. That's what we ordered for you, so you can be healthy. So my first time encountering Dr. Kimbrough was, I think we did an online session, kind of like this online health forum. And, you know, she has the ability to make you feel like you're the only one in the room. We were on the Zoom, but her smile was very welcoming. Her intellect was just superb, super sharp lady. She's going to share with us. Doc, we have a couple people who are still out, so they may walk in when you start. But whenever you're ready, you can start. Let's thank God for her. Is it on?
Yeah, we good. Okay, perfect. Thank you all for having me. Hopefully, I will try to make this as succinct as possible, but also to give you time to ask me questions, because there are some questions that came up that may not be in here, so I want to make sure I can answer those for you. My goal with this is just to introduce you to a few medications that are available for you, some you may hear, and hopefully give you some questions you can go back and ask your doctors to make sure that you're on the right medication for you in all. Next slide. Perfect. So the plan is to go through, do you need medication in the first place, which is a lot of what Dr. Matlock already talked to you about, and then to hit what type of medications we can choose from. Some of you may be on oral medications, which are just your pills. Some of you also may be on injectable medications you're taking once a week. And then, of course, there is insulin. That also may be in your repertoire if you have progressed to that point. And then to kind of go through those questions that you need to know. Next slide. So, do you need to take medication in general? So just like Dr. Matlock said, honestly, the best treatment for diabetes is meal planning, weight loss, and exercise. That's the best way to get your body back to where it needs to be. It helps reduce the number of medications you need to be on as well. And she went over a lot of what is the difference between type 1 diabetes and type 2 diabetes, so I won't belabor that point, but the goal is to know that with type 1 diabetes, you don't make insulin that you can use. And so those individuals normally will have to be on insulin. Whereas with type 2 diabetes, you have a lot of options because it's your body not processing the insulin the right way, not being sensitive enough to recognize it, as well as possibly making less of it as well. Next slide. So let's start with our oral medications. So there are some oral medications that are old that still a lot of doctors do use. These medications are called your alpha glucosidase inhibitors. Really unimportant, but essentially it's a type of sugar inhibitor that you can do. They work by blocking the absorption of sugar from your small intestine. They're also very low risk. And so some of us have that hypoglycemia unawareness that she was discussing. So for this medication, it will be good for those individuals because you don't have that risk of developing it. However, it causes very bad gas when you take these medications because they do work in your small intestine. So some people don't like that side effect. And then in those individuals who have ever had intestinal issues where you've had like obstruction, or if you've had an issue where you've had trouble having constipation, it might not be the best for you. You'll see on all of my slides cost of these medications because I'm also always very cost conscious for people because you want to be on your medications and we don't need to be putting you on medications you can't afford. So please make sure you let your doctor know if you can't afford your medication because there are options to tailor to you. And this is overall a very cheap drug. It's only $15 per 3-month supply most of the time. Next slide. These drugs called biguanides. A lot of you know this drug, metformin. Probably a lot of you don't like this drug at all because of its side effects as well. It works in your liver. to basically reduce the amount of sugar your liver is making, and then to increase the uptake of sugar into your muscles, where you do need sugar to kind of burn and help you work and move around. It also can increase your body's sensitivity to sugar. So this is a great drug, and why we normally start with it for type 2 diabetes, because of all of these benefits. It works regardless of what your insulin levels are. It doesn't cause you to gain weight. In fact, sometimes a few people can lose a little bit of weight on it, mainly because of the side effect issues, and you don't want to eat because of the side effects. You also have a low chance of hypoglycemia as well. However, if you have any type of liver issues, this is not a good drug for you. And also, if you have some kidney issues, the dose may have to be adjusted. So always paying attention to those facts when you talk to your doctor as well are important. It is another very inexpensive drug too, which is also why we start with it. Most of the time you can get a 90-day supply for $10 and you'll be okay. The next set of oral drugs are called bile acid sequestrants. So she talked to you a lot about statin drugs to help lower your cholesterol and to help make your cholesterol better. These drugs also work for both your cholesterol and your diabetes. However, how they work for diabetes, we really don't know. We just know that they do have a chance of reducing your A1C by about 1%. But with that added benefit of working on your cholesterol, it still makes it a good drug to kind of add on to some of those other medications. Other than that, it's not just used alone. There are really no major risk or side effects. Sometimes it can make you a little constipated because we do use these drugs to kind of slow down intestinal motility, but that would be the only thing that you'd really worry about. So if you used it in combination with your metformin, you can kind of reduce the side effects of the metformin. And it's also a very cheap drug. Now, this is the only one we call that we have FDA approved for diabetes specifically in the US. However, it can be used for like other mechanisms in the US, and the other brands you can buy offline or cheaper. Now, these drugs are some you will probably be hearing a ton about, and most people are trying to transition their patients to them, our DDP4 inhibitors. They work basically on some of the enzymes that are responsible for breaking down sugars and building sugars up in our body, and then they increase our insulin release by doing that and producing more hormone production in our small intestines. The benefits of these drugs are, one, they help you lose weight because they essentially slow down the motility within your stomach and your intestines, so you feel fuller for longer. They also have a low risk of hypoglycemia. The other issues or benefits with them are some of the conjunctions we're seeing with heart health benefits, as well as like kidney benefits in some of these medications. The main side effects, though, that are very worrisome and something we see more in women than men are urinary tract infections. And that's specifically because of how much sugar you're not absorbing, and then you kind of spill it off in your urine instead. So you do have to be careful with the dosages in these medications, and most of the time your physician will start you really low and slowly take it up so that you can kind of reduce those side effects. The other issue with these medications are they're pretty expensive. Generally, most insurances, they're about $50 for a 90-day supply. Some of the Medicare plans are getting a little bit better now that they're more widely used, getting it down to $25 or $30 for patients, but as you go up on your dosage, that kind of increases. Meglutides are in the next set of drugs. Both work by working in your pancreas. So for type 2 diabetes, we said that our problem is either we're not secreting enough insulin or we're not sensitive enough to it. So these kind of make your cells produce more of that insulin regardless. They're really good for those people who have really high blood sugars right after they eat and kind of reducing it quickly. And however, for someone that doesn't eat enough and doesn't eat regularly, your chances of getting very low blood sugars or your hypoglycemia are very high with these medications. The other main side effect is that you can gain a little bit of weight with these medications, and that's just because they work by bringing in fluids into your tissues in your body. So for someone who has heart issues where you already hold fluid and you take a water pill like a hydrochlorothiazide, or you take a Lasix or something like that, this would not be a good medication for you because of those side effects. They're also relatively, can be expensive, can be a little cheap, and it's about $30 normally on average, but anywhere from 20 to 40. These, the SGLT2 inhibitors, are another set of drugs that are pretty hot on the presses, something that everyone's using again because of their heart benefits, their kidney benefits. They also work in the kidney and kind of reduce how our kidneys take our blood sugar back up. So just like that DDP4 inhibitor medication, it can cause urinary tract infections as well and yeast infections. And so you have to be very careful, but the benefits for them again, are also that heart protective benefit. If you have heart disease, especially heart failure, where your ejection fraction, if you've heard that from your doctor, is low or reduced, this is a good medication for you because it reduces the risk of you ending up in the hospital because of that issue. Because wherever your sugar goes out your kidneys, just like when we spill salt out of our kidneys, water also goes. So it keeps that extra fluid off of your heart and helps it work a little bit better. Our sulfonylurea medications. So these are medications that are very, very cheap. They were some of the first medications we started using in conjunction with like your metformins and your other medications. However, they work to increase secretion of insulin in your pancreas, just like the others, but it doesn't matter what your blood glucose level is. So it doesn't matter if it's before you eat, after you eat, it'll just have your insulin levels high the whole time. So you can imagine if you're not eating, you have a very, very high risk of getting hypoglycemic with these medications. You also have the high risk of weight gain, but they can be used with other medicines so that you reduce those risks. Again, most of the time, these can sometimes be used with metformin. And since they're so cheap, it gives that option for someone that needs a little bit more help to get their A1C down without having to spend expensive amounts of money. And then lastly are our TZD medications, which just basically make your muscles use sugar more by increasing the uptake of the glucose from there and therefore your body is more sensitive to the insulin you already make. So in this case, you're not increasing how much your pancreas is putting out, you're just allowing it to be able to be used more efficiently. It can be used in patients who have renal disorders, which makes it a great medication if your kidneys have already been affected by your diabetes. However, again, it's also one that causes fluid retention, so not a good drug for people with heart issues. And then it also can't be used in women who may become pregnant. So you won't see us putting a lot of our 20-year-old type 2 diabetics on this medication because of the risk to the baby, or in a lot of our older women who don't have high vitamin D levels. We need to be checking all of your bone scans regularly because it increases your risk for fracture. And so that's why we always normally supplement people with vitamin D if we're putting them on this medication. All right, now moving to our injectables. These are drugs now that everyone wants to use, mainly because they have all the great benefits. However, they are very expensive and hard to get most of the time. You've probably heard of Trulicity. I know you've heard of Ozempic or Wegovy, because if you're going to your internal medicine doctor or your family medicine doctor right now, we're trying to put everyone on them. They can reduce a person's A1C in 3 months by 3 or 4 points. So for someone that's very close to where they should be, this can get you there easily if you're changing your diet, doing a little bit of exercising, and all the things that are beneficial. And it's because they act on so many areas. They're acting on your pancreas, they're acting on your stomach, and they're acting on your intestines and your liver. So therefore you're hitting all the areas where either sugar is being produced, sugar needs to be used, or you need to produce more insulin. The main risk for these are in your pancreas. They can cause what we call a necrotizing pancreatitis, where basically because your pancreas is working so much, it gets kind of inflamed, infected, that kind of thing. If you drink, these are not good medications for you because that risk is even higher because your pancreas has already been overactive. And then GI upset is the other big one. Most of these will cause very bad gas, diarrhea, as you're stepping up on the doses, especially if you go up too fast. So you have to kind of let your doctor know if they put you on one. On average, the first time you get this drug, it's about $50 to $75 for your starter pack. And then after that, it goes down to maybe $30 a month instead of every 3 months. But most people don't need to be on them either for that long to get their blood sugars under control if they're doing everything else, and then you can go back to some of those other medications to maintain it. You take most of these once a week, though. So for someone who has trouble like remembering when to take their medicine or being able to take a medicine every day, this is a good choice because you can take it on Sunday every week and you're done. And then lastly are our insulins. So this is what our type 1 diabetics will always be on. Our type 2 diabetics may be on insulin in combination with a lot of these oral medications. And so when you're thinking about insulin, or when we're giving you insulin, we're thinking about two things. How can we mimic how your body normally makes insulin and uses it? And then what's the most affordable for you? So our fast-acting insulin or our prandial insulin means insulin that you take right when you're about to eat, because this insulin will kind of handle all those sugars you're about to put in your body. It can be a little hard. It might also be called a sliding scale. You kind of hear from your doctor as well if they don't know how to measure how many carbohydrates they're taking in or look at their food labels as much. However, this kind of insulin works very quickly. It kind of hits its highest level in your body within 1 to 2 hours, and it sits around for 4 or 6. And these will be like your Lispro, sometimes your Novolog comes like this, your Aspart, or your regular human insulin if you end up in the hospital. That's something we normally use or you hear. Then we have our intermediate acting insulin. So these insulins are very cheap. And so a lot of you may find out, especially with Medicare, this is the cheapest insulin you can buy. Even without Medicare, it's probably the cheapest you can buy if you don't have any insurance. They come on in 1 to 2 hours. They can definitely control your blood sugar overnight without you having to worry about it. They last for 12 hours. So if constantly injecting yourself, being able to do insulin with meals is very hard, this is always an option for you, and if you're noticing you're struggling with that. So this is what we call our NPH insulin that you take twice a day. Take 1 in the morning, 1 before night, or 70-30 insulin, which has a mix of both that regular insulin and that little short-acting that your doctor can work with you to try to figure out how much you truly need throughout the day and give you a way to adjust at home. And then lastly is your long-acting or your basal insulin. So this insulin truly should be your insulin that stays on board the whole time. So for a lot of us, we need both of these, the long-acting and the fast-acting, so that way we can keep our blood sugar steady throughout the day. Your long-acting insulin kind of onsets in 2 hours. We try to mimic as close to possible what your body should need, and so we'll calculate that with you based either on your weight or what you're requiring, how high your blood sugars are getting. And then it can last 12 to 24 hours. Most of the time, we're choosing between Glargine or Detamir, but in your package, you should have a pamphlet with a lot of different types of long-acting insulin as well, and pens, because that's a lot of what we're switching to instead of vials, to allow people better chances to get them and use the insulin better. And some of those are higher concentrated. Now, the most important part. How do you figure out what's right for you? So as an internist, we go by 3 different organizations to kind of determine how we help our patients and what our goals are for their insulin. That's the American Diabetes Association, the American College of Physicians, and then the American Association of Clinical Endocrinology. They each have guidelines on how far we should be reducing our patients' hemoglobin A1C within each visit and what a goal target level should be. So for most adults who aren't pregnant, you should have an A1C of less than 7. For most older individuals, we normally say anywhere from 8 to 9 also is acceptable, because that reduces your chance of going really low in your sleep where no one may know. Then for our pregnant individuals, pregnant ladies, we try to get them less than 6. And that's also to reduce the side effects that may happen on the baby, because a mother with gestational diabetes kind of causes insulin issues with her baby, and when they come out, they can be very hypoglycemic, which can damage their development as well. And then also, you also have to know your other medical issues. So as I mentioned a lot, there's some of these medications, they affect your heart, they can affect your liver, they can affect your kidney. So knowing your kidney numbers, knowing your heart numbers Whether or not you have high blood pressure, whether or not you have some reduced function of your heart is super important when you're talking to your doctor about what medication to start for you. And then lastly, a lot of the same, and what I really want to leave you with is knowing you can always tell your doctor, I can't afford this, and they should be able to come up with an option for you. That's very important, because the goal is to help treat your disease, not to make it a burden for you to treat your disease. Continue to eat healthy and work out, because that's still going to be the best thing to sensitize you back. The Mediterranean diet, the DASH diet, both are great options, and both will work wonders. Always keep a log of your blood sugars. The one thing that helps us out the most is if you can bring something in so we can see what you're doing at home, because that ensures that your doctor doesn't overshoot and give you too much insulin, and you're at home feeling really sick, really tired, and then you stop taking the medicine altogether. That doesn't benefit you, and it doesn't get you to your goals. Always remember to express your concerns, and then always have a question when you come to your doctor. I'm a big proponent of never leaving your doctor's office without asking them something about your health, because that shows them that you're engaged. I promise you they will work harder, they will work more with you, and be more willing to make sure they're listening to your concerns if it seems like you're trying to work on your health as well. Okay? Any questions? I know I went through that super fast.
But metformin, is it dangerous anymore? People are saying it's a danger tool.
Yes, ma'am. It's not that it is a dangerous medication. However, it can cause other issues in your body if you have other medical issues. So for people with kidney disease, metformin can cause some buildup of some acid to make you very sick. And so that's the worry with it. If your A1C is 7 and you're just on metformin by itself, glipizide, glipiride.
It says Skittles. It says Glimperprot. You know what?
Glipiride?
Glimepiride.
Oh, yes. So that's sulfonylurea. So yeah, so you're on that combination of metformin and the sulfonylurea. Those are very inexpensive medicines that can keep you at 7, but you probably, how's your diet? So that's not good. That's not good. So how long was your A1C much higher?
The highest I've ever known my A1C to be is an 8. And that's over the 40 years. So
Okay.
now it's like, Margie, the last third exam, which was 3 months ago, I was at 7.2, and I went back October, it was at 7. So, I mean, it's coming down, but what am I doing that it's hard to eat anymore? I don't need to be lying. I'm gaining weight, but not eating.
Have you had any of your other numbers checked? Have you had your heart checked?
Heart check.
Okay.
Blood pressure is always normal. Kidney level, everything is normal.
I mean, to me, you're reaching your goal, with a medicine that sounds like isn't giving you too many side effects, that's been working well. So from a blood sugar standpoint, you wouldn't necessarily have to change it. But if you're concerned about something else, like let's say weight gain, for example, you might talk to your doctor and see if there's another option for you that would help with both your blood sugar and your weight. Now, it depends on if you're willing to take an injection, but some of those once a week, see? So sticking with the pills might be your best bet, and then working on your eating habits. Also, seeing a dietitian in your doctor's office is a great idea. They can help you work on, even if you're not eating a lot, they can help you work on your eating habits and help you kind of figure out what your best steps might be from that standpoint too. But yeah, it sounds like we don't want to go to, that once a week injection. So it sounds reasonable just with you reaching your A1C goal to continue your oral medicines, but then work with a dietitian on your eating habits and see if that'll help.
Well, I'll say I took Trulicity for some time, and that thing hurt so bad. It seems like that needle is like as big as a pencil. It was it hurt like really bad going in, but it was helpful. And so now I'm on something else that helps with once a week. But Trulicity was really good for me.
Yeah, they are great medications. I mean, they have so many benefits with weight loss and heart health and everything else. It is an injection, but it's a pen. So now it's a very small needle, just like an insulin needle. It's once a week. You can give it thigh, tummy, arms, anywhere.
The Trulicity wasn't small. It was like a pencil. That was a thick needle. It was a
Pastor,
painful.
you can't tell.
Viburian, that one doesn't have a big needle.
Yeah.
And then Victoza.
Ozempic doesn't either.
Yeah.
Ozempic is very small. It's a very
Ozempic
tiny
is
needle.
little. That Trulicity, I don't want to, I want the Trulicity people to come get me, but it was that thing hurt. But the other, you're right. The Ozempic is like a little bitty. You don't even know what's going on.
Very little.
And the Mounjaro they're coming out with now, that one, I mean, wow. The weight benefits and the blood sugar benefits are pretty amazing.
Yeah.
So if you can get on that, honestly, I think.
Which one is that?
Mounjaro, Mounjaro. They've done studies in type 2 and in weight, and it
Weight.
helps with both. Like, people are losing quite a bit to the point where some of these medicines, the weekly ones especially, there's like a shortage because like celebrities are paying $1,500 to
get the
get them
medicine.
to lose weight, you know? So like, that's how good they are, So, and I usually, for people who have trouble with metformin, if they have stomach upset, I'll switch them to, if they're willing to do the once a week injection, I'll switch them to one of those because it works quite well.
And let me also ask another question. Well, go ahead. I'll ask mine. She might be on. Go ahead, sister. I'm coming around there. Sister Ida.
I'm taking metformin 1,000 milligrams twice a day, and now my A1C is 6.2. And it always was in the 6. I was diagnosed with a 10, but ever since, I watch my diet, do exercise, watch my food, do eat some pig, but don't eat the whole pig.
Not the whole pig. Oh no.
But can I get off of the metformin and take the once a week injection?
As long as you still have a diagnosis of diabetes, which you're getting really close to not having, yes, ma'am. I will go talk to your doctor about it now.
Once a week?
Mm-hmm.
Okay.
Yes, ma'am. Yes, ma'am.
Is there a correlation with metformin and memory loss? Because I hear that a lot.
In memory loss? Not that I'm aware of. There's definitely a correlation with some other things, not necessarily memory loss.
Okay.
Yeah, I haven't heard that either. Typically, it's more so the stomach upset. And usually if you switch to like the extended release version, the one you do once a day, it can help with that. The risk of the stomach upset decreases with that. Also, if you take it consistently, so like a lot of times if people are off and on, you're gonna have a harder issue with the stomach upset. But if you take it consistently and kind of push through that first week, it gets better. Take it with food, non-greasy foods especially. So if you having your, pig that night,
Don't take it.
If you're having pizza, don't take it with that. Maybe just take it with a smaller snack earlier. But yeah, that's really the main issue, I would say, other than thinking about the buildup of acid if you have kidney disease or a liver issue. But it's one of the only medicines that FDA approved for children with type 2 diabetes. So I use it a lot. But when we can't, do it because of the stomach upset, we have to find other ways.
Dr. Kimber, what do you do when your blood sugar is low? Like if you know you have low blood sugar, and we've had this happen to people we've had this happen just in general. What do you do? Because sometimes there's a tendency to overtreat it, and so you end up with the spike. So what do you do when you have blood sugar low?
So the first thing is always just to eat. Juice is something that has a lot of high sugar content is what we go to, unless it's to the point where it's so low that you need medication to bring it up. Because then you should possibly be by a hospital or at least by an emergency room if we're doing one of our glucagon injections or something of that nature. Most diabetics, or at least my diabetics, I give glucose tabs to have with them so that they can take those too, which will bring it up quickly as well. And then you're rechecking it every 30 minutes or so to make sure you're actually coming up so you don't overshoot it. Recognizing when it's low as well. If you're at home and you're noticing that every morning you wake up, you're less than 70, you're less than 60, and you're taking your insulin at night or something, that's a fine time to send a message, call your doctor, get an appointment, because your medications may need to be adjusted too. Some people have lower blood sugars at night, which is also why we tend to decrease your doses during the night and have you on higher doses for your morning insulins and therapies to try to mitigate that so you don't have that effect.
And for my pediatric patients, I usually say 15 grams of simple carbs, recheck in 15 minutes. So they probably do more like juices and glucose tabs, applesauce, dry fruit, hard candies, no chocolate because that takes too long to bring your sugar back up, and then have a snack with some protein in it after that.
My question is there a side effect to the pump, having a pump? My grandson has a pump. Is there a side effect, and will he be able to continue to have the pump going into adulthood?
So I can answer the second part of that question. Yes, we have a lot of adults who are on insulin pumps with type 1 diabetes that we manage and monitor constantly. So that him learning how to use it as a child makes it much easier as an adult versus someone with adult onset type 1 diabetes and trying to manage a pump. The only side effects that I have noticed that have happened with patients who have pumps are when they get sick. But most of your endocrinologists kind of talk to you about what to do on your sick days, where you might need to reduce the amount of insulin, like your basal insulin or your continuous rate when you're having those sick days so you don't overshoot it and end up hypoglycemic or end up sending yourself into DKA if it's not enough sugar because you're sick as well, because your body does do different things when you are a type 1 diabetic on the insulin pump.
Yeah, and that's the thing, there's no difference as far as side effects of giving insulin through a pump versus through injections. So the side effect profile is going to be the same. With any time you're on insulin and some of these other medicines, you have a risk of low blood sugar, right? But that's the same as if you're on injections versus a pump. So nothing different there. The one thing we do watch out for with injections and pumps is making sure that we're rotating our injection and pump sites because you can build up scar tissue there, and sometimes if you use the same place over and over, there is risk of infection as well. But yeah, otherwise, like Dr. Kimbrough was saying, adults use insulin pumps as well. They can be used long term. We just have to make sure that we keep it on, because if you don't, it's as if you've missed your long-acting insulin too that day. And so that gives you a bigger risk of going into diabetic ketoacidosis. But if you keep the pump on, it'll continuously give you insulin 24 hours a day to keep you from making ketones and getting sick.
And I have another question, and we'll wrap this session up unless we have more. Does it matter where you take the insulin? I was always trained to take it here, and so I always take it here. But over years of taking it right around here, it gets to be a little kind of tough. So can you take it in other places?
Essentially, you just want to take it somewhere where you have subcutaneous fat tissue. So I know occasionally we tell, yeah, here, flank, stomach, but also like upper thighs are kind of fatty as well that you can use. I find it to be harder for patients to try to give themselves like insulin on the outside of their arm and actually do their needles, but like thighs and stomach are the normal areas.
Okay. Any more questions for Dr. Kimbrough? Ask away. She's here. She's standing right there. Okay, go ahead, Brother Ricky. I'm coming your way.
I keep having the same symptoms. Every time I urinate, my feet and my fingers burn. Is there anything to do about, can be done about that?
So that is definitely neuropathy likely. The best thing to do, honestly, is where you are with your blood sugar control. For your feet, you can also wear compression socks. I know they will hurt the first time you put them on. So you have to go get them fitted, and there are different types. So finding out like your actual width of your calf muscle, those types of things make it easier for you to get them. Medication-wise, if you don't have kidney issues, like Dr. Matlock said, gabapentin, Lyrica may work a little bit better, not with the drowsiness, and then that duloxetine medication as well. It's another add-on that can kind of help with the tingling. It tends to work a little bit better on top of the gabapentin than it does like using them separately though. Duloxetine or Cymbalta is another name for it. And then of course that vascular procedure, that vascular surgery is currently working on. So if your doctor wanted to send you in to see, I believe MUSC is involved in the clinical trials right now for it. That's an option as well. But the actual benefits, risk for it, I can't tell you all of them. But it's essentially readjusting the flow. So you have to make sure every other part of your body is able to handle that procedure too. So they'll do cardiovascular checks, lung checks, that kind of thing, before they'll allow you to be into it.
Any other questions for Dr. Kimbrough? Go ahead, Sister Veronica.
Ankle and my feet, they're like hot flashes. So would that be neuropathy?
It only started after your knee surgery?
Yes.
Does it go below your knee or?
Yeah, to my ankle and my feet. Real bad, like tingling, burning, hot flashes.
The hot flashes may be a different component. That can be blood sugar issues, that could just be hormonal changes. But the tingling, if you didn't have it before then, could just be is it just one leg or both?
Both.
Both? Okay, so you but you had knee surgery on one knee?
Yes.
Okay, so yes, then it's probably neuropathy and blood sugar control. If it's worse in the leg with the actual knee surgery, it could have just been nerve damage from the actual procedure, which happens sometimes after knee surgery. But the same medications will work just the same.
Medication?
Yes, ma'am, the gabapentin or the Lyrica or the duloxetine.
Yes, well, the foot doctor, recently I just started seeing a foot doctor, and she put me on gabapentin about maybe 2 weeks ago, but it doesn't ease my pain, my arthritis.
What dose are you on? How much are you taking?
Oh gosh, I can't.
You saw a podiatrist or did you see your actual doctor?
Podiatrist.
Okay, I would go back to your actual doctor, your like internist doctor.
Yeah.
Let them do your lab work because they may have been afraid based on what your labs are to titrate up your dose. Because a lot of people, are your problems worse at night?
No, anytime.
Anytime? Okay. So then you kind of need a steady dose throughout the day. And so you may just need to add in an extra dose to make sure you keep it under control and it doesn't build back up.
Okay, thank you.
You know, speaking of feet, here comes Sister Will. Speaking of feet, I was talking to a church member once who's diabetic, and we were talking about diabetes. And she said, I get my toenails cut professionally when I go get my pedicure. And I said, I don't think that's the same thing. Is that the same thing?
That is not the same
Okay,
thing.
talk about that, because some people think going to the pedicure shop and getting the nails is like for real safe. You know.
Yeah, it can be very unsafe for a person that's diabetic to go to a regular nail salon to get their feet taken care of. You do need to be seeing a podiatrist, if not twice a year is normally what I tell my patients, at a minimum once a year, to evaluate your feet. And then if you're going to a pedicure shop, you need to make sure they're not scraping your feet, they're not using graters on your feet, anything that can cause any type of open wound on your feet that you may not have sensation to, because once that neuropathy starts, your sensation in your toes and your feet starts to go away. And those wounds are what eventually lead to chronic wounds and chronic infections and lead to amputations of your limbs. So you have to be very careful. They shouldn't be cutting your nails short. They shouldn't be trying to dig out ingrown toenails, those types of things. You leave that to a professional and you go to your podiatrist for that.
I'm sorry, y'all. I'm sorry. I'm sorry. I know y'all ladies liked it, but that's not the same. It's not the same. She hadn't gone to medical school.
Yeah, get them
The lady
polished
at
and
the
go, but.
yeah, but the lady at the nail salon did not go to medical school. She's gonna mess up your foot.
I'm taking one metformin a day. My doctor had written a prescription for me to maybe take 2 because of the nerve pain that I was having in my foot. But I'm only taking 1 because metformin makes me sleepy. I don't know how it affects others, but I cannot take 2. I cannot tolerate 2. I don't want to take the 1, but I don't want to tolerate the nerve pain either.
Metformin?
Metformin,
For the nerve, what's your A1C?
5.5.
Why are you on met? We made,
Metformin. I take that at night. The long yellow pill, the metformin. I take it every night.
You need to go back and see which doctor are you seeing. I would ask for a referral to an endocrinologist.
My doctor is in the same area where you all are.
Okay.
135 Rutledge Avenue.
Mm-hmm.
Right there. I've been seeing him for years.
Because you shouldn't, if your A1C is 5.5.
5.5. I've never had a high A1C from the time I was diagnosed as a diabetic. But right now I'm a controlled diabetic because
Are you controlling it with diet? Like, are you
I'm
eating?
controlled with not taking any medication other than the metformin that I'm taking once a day.
It
Just-
sounds like you're
just
diet
one.
controlling. You don't need the metformin
Okay.
at all, but I can't, of course, I'm not your doctor, so I can't make that decision. I would go back and talk to them because theoretically metformin shouldn't make your blood sugar that low to where you get sleepy unless something else is going on.
Well, I was taking 100 milligrams of the blood pressure medicine. And because my blood pressure went down so low, he cut me down to 50. So
Now
I took
that
my-
may be causing you to get, are you taking them together? Do you take your metformin and your
No, I
blood
don't
pressure
take
medicine?
them together.
You don't? Okay.
Take the blood pressure medicine in the morning,
Okay.
and that's the only time I take it, once a day,
Okay.
50 milligrams.
Because it can, if your blood pressure is dropping that low, that can definitely make you get sleepy, tired, very like out of it. So it may even need to be reduced more. And if it's a once a day medicine or something that stays on 24 hours, that's another consideration. But I would definitely still talk to them about if you have a 5.5 A1C and your diet is healthy and that kind of thing, you don't necessarily need to be on metformin.
Let's give God thanks and praise for Dr. Kimbrough. She did an amazing job. Both of the medical professionals that we've heard from have made this really fun and engaging, and we have one more. I'm going to give you a grown-up break, and if you have other questions, they're sitting there. If you may want to, can they walk up and ask a question real quick if they need to? And if they need to have other questions, they'll be right there for us. Give you a grown-up break, and then we're coming back with the illustrious Elizabeth Biggers Bernay. She's going to talk to us from the Waring Center. So take a grown-up break, and we'll come right back.
Dr. Kimbrough has to run, and so we want to, come on up. Come on up. We want to thank God for her. She's super busy, as everybody is, so let's thank God for her. Amen. And we do have a policy here. Anybody who comes and shares is prayed for. So I hope you don't mind me praying for you. We'll take care of you before you leave, unless you need to leave right now too. Okay, all right. We'll get you so that Ms. Bernay is not by herself. All right, okay. God, in the name of Jesus, we thank you for your love and your mercy and your kindness. And we thank you for the gifts that you have placed inside of Dr. Kimbrough, God. For her compassion, which is evident in the way she talks to those that she cares for her insight into the medical field, and for her genuine concern about the health and well-being of others. We thank you, God. And it comes out of her as she speaks. And I pray, God, that you would just magnify that in her, that you would give her a passion to help others more and more. But not only that, God, but we pray that you bless her personal life, her health, God, her mental health. Bless every part of her, God. Help her to be whole and well as she moves about your word, doing your work in the name of Jesus. I pray her safety. I pray her health. I pray her faith grows more and more in you in these days. God, we thank you for her in Jesus' name. Amen. God bless you. God bless you. God bless you. God bless you. Big hug. All right. That's a gift. We cannot pay you for what you do, but just take a gift, okay? All right. God bless you. Thank you. All right. Take a break, everybody. Well, it's good to have you. We're going to get you started here in just a second. Just a second. Oh, any of you who are baseball fans know that some of the players in baseball play throughout the whole game, but then at the end, somebody comes in and bats cleanup. And the cleanup batter is the one that's just going to knock it all the way out of the park to make sure that the team wins the game. Well, we have a cleanup batter on today who is going to just add to all the amazing information that we have heard, and she is Elizabeth Biggers Bernay, and she works with she's the director of the Waring Center. Anybody ever went to the Waring Center, to the senior center, the Low Country Senior Center? Anybody ever? Oh, okay, there we go. We have some disciples here that go there. And so she's going to talk to us about the diabetes prevention program they have there. Let's thank God for her. Amen. Amen. And I think that is your mic. Okay, there you go. That's your mic.
And I told you, I talk really loud. Which has, all right, I'm not going to touch it, but okay, I talk really loud anyway, though. So, but if you have pre-diabetes, obviously you are at risk for developing diabetes, but you're at higher risk for heart disease, stroke, and obviously type 2 diabetes. But it is reversible. You don't have to automatically go from pre-diabetes to diabetes. But if you're at risk for diabetes or have pre-diabetes and you take no action and you don't do anything about it, more than likely you are going to have diabetes in about 5 years, and that's the case for most people. So I do have in your handout, so are you at risk? If you have pre-diabetes, like I said, you have elevated blood sugar, and your doctor's probably going to tell you. If you're at risk, a lot of people are at risk, and so put it to this way: if you have diabetes, then more than likely people in your family are at risk for diabetes, and so you might want to give them this test. But this is a simple test that, and you just kind of fill it out. You find your weight, and you put a 1 for everything. If you add it up, if you have a score of 5 or higher, then you are at risk for diabetes. And you should consider this course that I'm about to talk to you. So this is a really good course for, and you'll see that it says, how old are you? Are you a man or a woman? Men get a 1. Women, luckily for once, we don't have to put a 1 down. If you were ever diagnosed with gestational diabetes, if you have a mother, father, sister, or brother with diabetes, then you need to put a 1 down. Have you ever been diagnosed with high blood pressure? That puts you at higher risk. Are you physically active? And your weight, and it's got a scale right there where you can find your height and your weight, and then if you fall, it'll tell you if you should put down 1 point, 2 points, and for some people, you automatically jump to 3 points. Yes, ma'am? It is, we were passing it around. I know it's,
Who doesn't have it? I'll make sure you get it.
okay. So this, yeah, so we'll get this to you. I brought a ton, so I know they're around here somewhere. So this is good to take, and you also, like I said, you might give it to somebody else in your family if you're worried about them. So, but I'm going to now talk to you about the pre-diabetes, and I'll get to my slides if we could put those up. But I'm going to talk to you about the Prevent T2, or we also just call it the Diabetes Prevention Program. And this course, this workshop, was developed by the CDC. So, and it's offered all over the country, and it is recommended. It has been tested. It has been researched. It is considered to be an evidence-based program. So there's a lot of science behind it to show that it works. And you will actually, it's a year long. That's why it's so successful and why it works, because you're not going to lose weight and make these changes quickly. It's hard to make these changes and stick to them. So you actually work with a trained lifestyle coach. For example, I went and got the training. I got training out of Emory, at a program out of Emory University in Atlanta, and along with a couple of other of my coworkers. We have several of us. And it's a full year, it's 12 months, and you're going to work on 2 things. We're going to work on changing your diet and being more physically active. So those are our 2 goals for the entire year. And we also talk about a lot of other things, such as managing stress, how to stay motivated. We're going to set action plans at every time we meet. And we start off, and I'll go into this later. So I'll just keep talking and talking and talking, and I have to stay on track. But we solve problems. So it's hard. A lot of times when you go to try something new, and it doesn't work, you run into challenges. Well, we're going to learn how to recognize those challenges and solve problems. And it's a group setting. I'm really more of a facilitator than anything else. And you'll end up learning so much from each other and helping others in the class as well. I mean, everyone runs into the same problem. Like, for example, one group, you know what happens this time, this weather right now, what kind of challenges does this present to exercise? Yeah, it's too cold, right? It is too cold to get out and do my walk. Everyone has that problem. I mean, everyone feels that way. And then in the summer, too hot. So, I mean, yeah, everyone runs into those problems. The holidays are coming up. You got Thanksgiving, and it just runs right into Christmas, and it runs right into New Year's. What kind of, what kind of problems do you have with that? Leftovers. Yes, too much food, you know. So how do you eat healthy? How do I say no to that cake? How do I say no to that cookie? You are not the only one who has that problem. Everyone does. And so then when we get in these workshops, we talk about that, and everybody shares their tips. And, you know, like I learned one woman, she goes, I get one cookie, and I put it on a plate, and I set it aside, and that's it. And then she talks about how she'll eat it later on, not in front. Okay, so she eats it right then. For her, you know, she'll end up going right back to the tray and getting 3 more. You know, so anyway, but you learn a lot of good tips. So that's why I think that another reason that this is so successful, and when you come together as a group of people, you're meeting all year long, you really get to know people. And at the end of the year, you're going to be like, I don't want to stop coming. I want to keep meeting. And so we actually are now starting to set up like a support group. And I hate to call it a support group, but just like for people who graduated the program, you're going to come back once a month and see other people, and we'll still talk about different issues and different topics. But again, we set action plans every week. You report back, you talk about your challenges, you get help from other people, you get ideas from other people who are just like you and facing the same struggles. And I think that's what's so powerful, because you're not by yourself. I mean, I can't tell you how many times, you know, you feel like, it's like, man, you know, you get on the scale, and half the time you're the only one in the bathroom, and you're the only one seeing that number, and you're just like, it's just defeating, and you get upset. But you're really not, and so that's why it's so wonderful and so powerful to come together with a group of people who are like saying the same thing. Yes, I gained a couple of pounds, but you know what? When I look at it, I know I really didn't do my walk this week, or I know I didn't, you know, and you can talk about it, and you don't feel so bad about it, and you feel uplifted, and you can keep going. And those are just some of the tools that you'll learn. And the next slide is, I think this is very powerful. I said this is research-based. Their research shows that people who completed the workshop cut their risk of developing type 2 diabetes by 58%, those who are pre-diabetic. And if you were 60 years and older, it jumps to over 70%. 60 years and older, over 70% of the people who took this workshop and did the whole thing and really worked at it, they cut their risk of developing full-fledged diabetes. So you can prevent it, and it is preventable. It's not a definite. So, and I think those are just some really powerful statistics. The other thing I'll say is this is not a fad diet. You know, a fad diet, you know, those are going to be, they're short-lived. And you might see an improvement, but a lot of times those diets are not sustainable. You can do it for, you know, maybe you can even do it for 12 weeks, 3 months, but then you can't keep doing it that long because it's just not realistic. You did it to lose weight, maybe for one event that was coming up because you wanted to get in that dress and look good on that day. But then after that time period's up, you know, you're going to gain the weight back, and a lot of times you gain even more weight back. So this is not really, I wouldn't even call this a diet. This is a lifestyle program, and that's why the people who facilitate it, we're called lifestyle coaches. We're going to be talking about making permanent changes to the way you eat and the way you live your life on a daily basis. And I do have a video, so we will put up the video. And again, this is out of the CDC, put the video together. Oh, there's me. We'll get it up here in just 1 second.
All right, back again, week 13 of our diabetes prevention program, physical activity, yay!
The classes that are part of the National Diabetes Prevention Program work because they have been studied and tested. We have known for some time now, based on really well done research studies, that you can prevent or postpone type 2 diabetes. This is the opportunity for us to implement those findings in a way that the population can experience it.
Tim, looking at how far you've come, what else what else is out there? Where else do you want to go? In their core 16 weeks of this program, participant will come in and meet once a week with their facilitator and their small group. We'll sit down and we'll discuss one of our 16 lifestyle topics for that day.
I've been pre-diabetic for over 2.5 years, and I've just kind of ignored it because that word pre was there.
I knew that my blood sugar was high. I would watch my diet a little bit and then I would stop, but I didn't do anything consistent.
We're going to try it again in just a second.
The classes that are part of the National Diabetes Prevention Program work because they have been studied and tested. We have known for some time now, based on really well done research studies, that you can prevent or postpone type 2 diabetes. This is the opportunity for us to implement those findings in a way that the population.
Okay. While we're waiting, there we go.
All right, back again, week 13 of our diabetes prevention program, physical activity, yay!
The classes that are part of the National Diabetes Prevention Program work because they have been studied and tested. We have known for some time now, based on really well done research studies, that you can prevent or postpone type 2 diabetes. This is the opportunity for us to implement those findings in a way that the population can experience it.
Tim, looking at how far you've come, what else what else is out there? Where else do you want to go? In their core 16 weeks of this program, participant will come in and meet once a week with their facilitator and their small group. We'll sit down and we'll discuss one of our 16 lifestyle topics for that day.
I've been pre-diabetic for over 2.5 years, and I've just kind of ignored it because that word pre was there.
I knew that my blood sugar was high. I would watch my diet a little bit and then I would stop, but I didn't do anything consistently on a consistent basis.
There's an issue with the patients not realizing the problem is as bad as it is or as bad as it may become.
Chicken burgers, and they all had them. The first few weeks of the program, we're talking all about fat gram intake, behavior modification, your level of activity and how physically active that you are during the day, and stress management.
Stress management is a very important piece when it comes to lifestyle change. It affects people's eating, it affects people's physical activity, it affects everything that has to do with lifestyle change.
A lot of people think you have to have machines and tracks and things like that to constitute exercise. But what we look at in the class is how active are you really throughout the day?
I like to walk early in the morning. It gets your day started, and it's a good little power walk, and it's free. It doesn't cost anything to walk here.
5, 6,
Initially, I was in denial about the fact that there's a higher percentage of African Americans affected by diabetes than other ethnic groups. But all around me, friends, family, church members, I was seeing younger and younger people affected by the disease. One of the things that we were required to do was to set a goal of weight loss, set a nutritional goal, because we established what our fat gram content had to be for the day. We were to set in our books exactly how many minutes we were going to exercise every day.
The real success is that people are working together to try to find the solutions and to support each other.
Without the class, I would have never done this on my own because I had tried. I had done every single thing out there that I could think of.
My hope for this program is that many physicians across our community will use this resource as their first line of defense against type 2 diabetes. That's what our program is here for.
This is really the example of what we wish would happen in many fronts, is that the government, the private sector, and the community sector would really join forces and come together to solve these problems.
My patients love the idea of being able to have a program to be healthier going forward. My patients really love that. They're surprised that they can actually get older and be on fewer medications.
I am so excited because I went to the doctor last week. All of my numbers were down, and I am officially no longer pre-diabetic.
There are almost 80 million people that have pre-diabetes. My dream is that in the next few years, it will be easy for people to get access to this program. And ultimately, we will be able to say fewer people are developing type 2 diabetes.
So that gives you a little glimpse into the program. Again, it's designed to be implemented and replicated in community settings. That's why we offer it at the senior center. It's a convenient, easy place to come and do something like this. They are offered across the community. We're not the only ones, even here in Charleston, offering this class. I was just mentioning MUSC offers it. And other community locations anybody can, you get trained and you can come in and offer this type of class. But it's very, there are a lot of handouts. I've got a script, I have a curriculum that I lead so that they know that no matter who's implementing it, it's gonna be the same. It's gonna be implemented the same way at every location. So like I mentioned, it's a year long. The first 16 sessions are once a week. So we meet once a week for 16 weeks. And during those first 16 weeks, what we're really trying to do is to lose weight. The goal is between 5 and 7% of your current body weight, and to get at least 150 minutes of physical activity per week. And so those are our goals. And then after that, we actually meet for the next, we go I think 3 months where we meet twice a week. And then towards the end, the last 3 or 4 months, we just meet once a week. So we taper off, and that's how it ends up. So it's not like you're meeting every week for the full year. But it's really, like I think you saw, it's a very powerful class. A lot of people feel like, it's kind of like you know what you need to do, but doing it is the hardest part. And that's where being in a group with other people who are facing some of the same issues, what makes it so powerful. And then I mentioned this also, so each week, and I did bring so we're offering, we will be offering one here on James Island in January, and I'll give you that in a minute, but I list out my 26 sessions, or how many sessions we do. And so some of the topics is like how to get active to prevent type 2 diabetes, how to track your activity, you eat well to prevent type 2, we track your food, how to get more active, how to burn more calories than you take in, how to shop and cook to prevent type 2 diabetes, how to manage stress, finding time for fitness, coping with triggers. We all have triggers. That's that thing that is like, oh man, as soon as that happens, next thing you know, you're eating like you shouldn't be, you know. Heart health, you know, how to manage your thoughts, getting support. I mean, eating healthy when you're away from home. So there's all kinds of topics that we go over during the course of the year. And then your role, and when you take it, so you mentioned, they mentioned it in the video, how they had a booklet. So you'll get paperwork and every week, and you will track your activity. So it's not, there is a lot of work on your part as a participant. It's not just coming to the class. These are things you've got to do every day in between sessions, but you're going to have a log where you track the minutes of physical activity that you get every day. You're going to log your food that you eat every day. And then you're going to bring in your log at a little bit before class. So the class is just like 1 hour, but we ask that you start coming in about 30 minutes before class, and we're gonna weigh in, we're gonna track your weight. You'll have a log for your weight for each session. And then you also gonna have a little bit of time to sit down with your coach, if it's me, or it might be someone else, and we'll kind of review what you did since the last session and talk about what worked and what didn't work. So there are going to be all kinds of other things that we talk about in the class that we're going to, like on managing stress, for example. We might give you some ideas of maybe some meditation or some just different ways that you're going to try. You're going to set an action plan. Okay, this week I'm going to do this to manage stress, and then you're going to come back in and you're going to have written about it and track it and talk about it. And then the next couple of slides are just, you know, samples of the action plan log. And action plans, you know, are very, very specific. It is, all right, I will do this between now and next week when we meet. And it's going to be, I will walk for 30 minutes. And we're going to talk about when. I'm going to do it Monday, Wednesday, and Friday. I will do it after my lunch at 2 o'clock in the afternoon. Where are you going to do it? So we get very, very specific, because that is a tool that you'll learn in this workshop, is that the